Hello everybody, this is Dr. Christy Day. This video is aimed at providing study tips for men's health. I have broken up the content by weeks instead of combining all the content into one large review. The video is not a comprehensive lecture on the content material, but instead my aim is to highlight some topics and focus your studies. Your major source of study for this week is your textbook, Fitzgerald Amplify, and course lectures. Of course, this video review is optional to listen to. This is the list of topics that will be covered for men's health. I highly recommend that you approach your studies focusing on these problems and their risks, symptoms, clinical presentation, screening or diagnostic testing, diagnostic criteria, and treatment. Understanding the content in this way will help you in your clinical practice, in course exams, and on your board exams. Benign prostatic hyperplasia, also called BPH, is the common name for nodular hyperplasia of the prostate. It's one of the most common conditions affecting patients over the age of 40. The prostate is usually walnut-sized, and of course it's positioned at the base of the bladder in front of the rectum in men. This gland starts enlarging in puberty and stops growing at around age 20, and then it begins to enlarge again after the age of 50 years. Risk factors for BPH include a family history. There are some inherited forms of BPH, and these types are predominant in men under 60 years old. Aging is a primary factor. BPH occurs in 8 to 20% of males by age 40 and 70 to 90% by age 80. So the vast majority of men will have BPH. Also, chronic or recurrent inflammation can contribute to BPH with lower urinary tract symptoms. This inflammation results from an autoimmune response or in response to chronic infection that affects normal prostate function. Symptoms: around 50% of men with BPH experience moderate to severe lower urinary tract symptoms. You can see on the slide that there's a questions. This is American Urological Association Symptom Index, and you can see some of those questions, and those are the symptoms of BPH. Not able to empty the bladder completely. Do you have to go again, urinate again in less than 2 hours after you finish urinating? There's a whole list of them, and you can review those. That's in your textbook. Diagnostic testing: always make sure that you exclude infection or hematuria with the urinalysis. If nocturia is the main concern, then do a nocturia evaluation, along with consider a sleep study to rule out obstructive sleep apnea or primary nocturnal polyuria. A PSA test is optional, but is usually done if the patient has a life expectancy of greater than 10 years. And this means that they would be eligible for prostate cancer screening if it was prostate cancer treatment such as surgery and radiation, those things, if they were to find prostate cancer. Normal PSA is less than 10. And we'll talk more about that later in prostate cancer screening and diagnosis in the later slides. Once prostate cancer has been ruled out, non-surgical medical management is usually tried initially to treat the symptoms. Most patients with BPH can be treated as outpatients, and the goal is to relieve the symptoms of dysfunctional urination, especially nocturia, because it impacts the quality of life. Inpatient treatment may be required to manage fluid and electrolyte abnormalities associated with significant obstructive uropathy. I once actually had a man that got a complete obstruction from BPH, and he left it untreated and ended up with end-stage renal failure and on dialysis permanently. Most urologists and primary care providers have adopted sort of a watchful waiting approach for patients with BPH who have only mild symptoms. A patient with mild to moderate symptoms, minimal PVR, and no objective changes in the urinary tract may only require monitoring. Thus, watchful waiting is considered the most conservative and the most appropriate approach for BPH, as long as more serious conditions have been ruled out. As far as medications, the prostate and bladder contain alpha-1 adrenergic receptors that cause the prostate and bladder neck to contract when they're bound. For this reason, alpha adrenergic blockade decreases this effect and results in objective and subjective improvement in the manifestations of BPH. So we want to prevent that bladder neck from contracting. Most of the alpha adrenergic blockers used in the treatment of BPH are selective alpha-1 adrenergic antagonists. These include silodicin, terazosin, and doxazosin. Another class of medication used to treat BPH is the 5-alpha reductase inhibitors, such as finasteride and dutasteride. These medications can reduce the size of the prostate, although it only really, the maximum decrease is about 20%. It can take up to 6 months of treatment. Improvement in symptoms in this class of medication is only seen in patients excuse me, with very enlarged prostates, greater than 40 grams. One of these medications, I'm sure you're familiar with, finasteride, is tolerated pretty well, but adverse effects include decreased ejaculate volume, reduced libido, and erectile dysfunction in 3 to 5% of patients that take it. The adverse effects can decrease over time, however, and they are reversible with stopping the treatment. And of course, the watchful waiting approach includes lifestyle changes such as avoiding caffeine, alcohol, spicy foods, and then we have the complementary medications of saw palmetto and African wild potato. And these are actually, you can find these in evidence-based practice, some studies on those that show that there may be some benefit to taking them. For additional resources on BPH, I've included a link to a Baylor College of Medicine video, and this is a comprehensive lecture on BPH, everything you need to know, and it's about 8 minutes long. This is the prostate screening chart that I picked up from your textbook, and it's a comparison of the various organizations that weigh in on PSA testing. And PSA testing is prostate-specific antigen, and it's, as you know, a screening for prostate cancer. One of the portions of the screening, USPSTF says that that men should have an opportunity to make a decision regarding PSA screening, and they should understand the benefits and the risks of doing that. And so there's a small benefit that they would receive by reducing the chance of death from prostate cancer in some men. But many men will experience potential harms of screening, including false positive tests. That these false positives would lead to additional testing and possible prostate biopsy. They can lead to overdiagnosis, overtreatment, and treatment complications such as incontinence and erectile dysfunction. So it's not without risk, and there is some benefit to having an early diagnosis. So the risk factors for prostate cancer include a family history, race and ethnicity, and also consider how comorbidity may interact with treatment for prostate cancer. So before they decide whether to get tested or not, they should think about their risk factors, and also understand that if they were to find a cancer, would they want to be treated? And if not, then they don't want to get tested. The American Cancer Society recommends informed decision making, so they are kind of like in the same school as USPSTF, and they recommend that men should be provided information regarding benefits, risks, and uncertainties of prostate cancer screening. And at age 50, the American Cancer Society says at age 50 that men who are at average risk and who are expected to live at least 10 more years should be screened. And men age 45 at higher risk, which includes African American men and men with a first degree relative, a father or brother, who has been diagnosed with prostate cancer at an early age, younger than 65, that they should consider screening. And then men for age 40 are at even higher risk, those with more than one first degree relative who had prostate cancer at an early age. So USPSTF is the major United States recommendations. They recommend for men between 55 and 69 that there's a shared decision making, and then they don't really make many more recommendations after that. Whereas the other American Urological Association and the American College of Physicians and American Cancer Society all have an opinion on that. And so it really, you just talk it over with your patients and see where they stand on this, what their thoughts are, and provide all of the information that you know so that they can make an informed decision. The most common age for cancer diagnosis is between 50 and 60 years of age. And 67% of males greater than 80 years old have been diagnosed with prostate cancer. And it's the most common cancer found in the United States for males. And it's number 3 on the list of cancer deaths for men. Risk factors: the clinical incidence of prostatic carcinoma is highest in North America and Europe, and the lowest in the Far East, suggesting that there may be a genetic, dietary, or environmental factors that increase prostate growth. Genetic susceptibility focuses on prostate cancers have been identified on several chromosomes through genome-wide studies. And they're consistent with a genetic predisposition. And like we talked about, in an individual with first degree relative, father or brother, and these people are twice as likely to develop disease and do so at an earlier age. In addition, occupational environmental risks are present for the development of prostate cancer, and they include some cadmium nitrates and heavy metals. And as an occupational group, farmers are at the highest risk for development of prostate cancer, which is kind of surprising, but most likely due to chemical exposure. And those at the highest risk for prostate cancer in the U.S. are African American males with a family history of prostate cancer, and those with a high diet high in fat, and particularly animal fat. Smoking has also been identified as an important risk factor for prostate cancer. And the risk appears to be proportional to the number of cigarettes smoked, which is maybe related to their cadmium content. A patient's endogenous hormonal influences, namely an increased level of testosterone, has also been shown to increase risk. So most men are asymptomatic in the early disease, and then when they start to develop symptoms, it's real similar to BPH. Later in the disease, of course, they have signs and symptoms of cancer, such as bone pain, weight loss, anemia, shortness of breath, lymphadenopathy, and lymphedema. If prostate cancer is suspected, and that's if a PSA is greater than 10, The patient should be referred to a urologist for a transrectal ultrasound guided biopsy of the prostate. Digital rectal examination may reveal a palpable hard prostate, and several hard areas may be noted, or nodules may be limited to one hardened area. Induration of the prostate may also be noted. Induration is indentions. Hematuria and hemospermia are signs that appear late in the course of the disease and are rarely detected in early prostate cancer. Evaluation or of absence of contraction of the rectal sphincter in response to squeezing of the glans penis, known as the Osinski reflex, may raise suspicion of possible lesion at the level of the conus medullaris of the spinal cord. The identification of malignancy using transrectal ultrasound guided biopsy is not only a conclusive diagnostic finding, that's how they diagnose us, but this procedure also provides information that is helpful in staging the disease and in planning treatment, which may include radiation and chemotherapy. Prostate screening uses a combination of DRE, TRUS, and PSA with age-related values, provides the greatest positive predictive value for diagnosing prostate cancer. And prostate cancer is treated by a team of specialists, most commonly including urologists who are surgeons, radiation oncologists, medical oncologists. Some other specialists may get involved, like interventional radiologists, uroradiologists, etc. This slide provides a look at the Gleason scoring. You don't need to memorize this, but it's good for you to know that it exists. And these graphics are from the American Association for Cancer Research. And I thought they were kind of pretty. Prostate tumors are classified according to the Gleason system, in which the initial score grade is applied to the architectural pattern of the cancer in the largest segment of the specimen. And then a second grade is given to the next largest area. And the pathologist adds the two scores together to produce the Gleason score, which is a scale of 1 to 10. Accurate staging provides an indication of the best treatment options. So you can see in here they've added, 4 plus 3, a Gleason score of 7. So a Gleason score of 6 means that the cancer has a low risk of growing and spreading. Gleason score 7 means it has an intermediate risk. And Gleason score 8, 9, or 10 mean the cancer has a high risk of growing and spreading, and these cancers are considered aggressive. Prostatitis is one of several inflammatory and/or painful conditions affecting the prostate gland. It accounts for about 25% of all office visits by male patients, and 50% of males will experience prostatitis in their lifetime. Classification of the type of prostatitis is important for both diagnostic and treatment purposes. Of course, if you have a good diagnosis, the treatment plan flows from that, right? So diagnosis is key. They may present with acute bacterial prostatitis, chronic bacterial prostatitis, non-bacterial prostatitis, or prostodynia. Chronic non-bacterial prostatitis is the most common type, and it's 8 times more frequent than bacterial prostatitis, which occurs more frequently in patients with HIV. Prostodynia is an outdated term for chronic non-bacterial prostatitis or chronic pelvic pain syndrome, CPPS. And CPPS is a condition characterized by chronic pelvic pain without signs of infection. Symptoms of the non-bacterial prostatitis will include pain in the groin, genitalia, painful or burning urination, frequent urination, and fatigue. And that sounds a lot like a UTI or an infectious prostatitis. The causes can be multifactorial and may include a past infection, nervous system issue, or even pelvic floor muscle problems. Acute prostatitis occurs predominantly in uh, sexually active patients between the age of 30 and 50 years. These are the acute bacterial prostatitis, whereas chronic bacterial prostatitis is more common in patients older than 50 years. Acute bacterial prostatitis is always associated with a UTI and has characteristically abrupt onset. Chronic bacterial prostatitis is a major cause of recurrent bacteria and is associated with a history of recurrent UTI, presumably due to repeated seeding of the urinary tract by an infected prostate. Risk factors for prostatitis include advanced age, older than 50 years, a history of previously diagnosed UTI, and a history of prostatic calculi. A urine sample from a patient with non-bacterial prostatitis will show the presence of WBCs, but the urine culture will be negative. There are no abnormal laboratory findings associated with prostatitis. Among patients with chronic prostatitis and chronic pelvic pain, prostatic massage effectively doubles the number of cases considered to be inflammatory versus infectious. And so this is important for antibiotic stewardship. We don't want to treat people for an infection that they don't have. The main principle of management for prostatitis is to treat the patient on an outpatient basis if they don't have a fever. However, extremely ill patients, of course, should be sent to the hospital. They should be admitted to the hospital and treated there. Your high risk for complications are immunocompromised, people who have had an abscess or have a suspected abscess, and people that look like they might have urosepsis. So you want to get those out of the clinic and into the hospital. Most patients with acute bacterial prostatitis can be treated as an outpatient with 5 days of Levaquin or Cipro. However, there's increasing concerns over antibiotic resistance and also with the fluoroquinolones, tendinitis and tendon rupture. And so because of this, we've seen recommendations for Bactrim, 10 to 14 days and an additional 2 weeks if the patient remains symptomatic after the first course. Chronic bacterial prostatitis, the best cure rates are associated with treatment with Levaquin, although other antibiotics have been shown to be effective as well. As with acute bacterial prostatitis, however, fluoroquinolones should only be used if there is no other effective alternative antibiotic choices. Patients with chronic infections usually are treated for 4 to 6 weeks, with an additional 4 to 6 weeks if the first course results in only a partial symptomatic response. And I will include a link to this in the timeline to a diagnosis and management of prostatitis, an excellent video, and it's not super long, so I do recommend that you may get a very clear picture and an understanding to hear this information again by another person with a professional presentation. Nocturia is currently defined by the International Continence Society as having to wake at night 1 or more times to void, each time being preceded and followed by sleep. Recording the number of times a patient urinates at night and making a reasonable estimate of the amount voided is extremely important. The frequency of urination may vary from large volumes of urine, polyuria, and to small quantities passed at frequent intervals. Adult males normally void 5 to 6 times during the day and once or not at all at night. As males age, nocturia is usually a sign of a prostate problem, and most often BPH. Typically, up to 50% of males older than 50 years have some symptoms of BPH. And typically, 59% of males get up to urinate at night at least twice by the age of 70 years. So when you see an older man or a man in his 50s and 60s, you say, "How you sleeping? Are you getting up at night to use the restroom?" And this is a great way to ask the question without focusing on that specific system. The occurrence of nocturia without discomfort may be due to diminished bladder capacity. So sometimes they just have, a smaller bladder. They have overflow incontinence, poor toileting habits, medications such as methyl-dopa, phenothiazines, diazepam, excess vitamin D, diuretics may also cause nocturia and or may aggravate incontinence. Drugs that cause urinary retention include alpha-adrenergic agents, androgens, sympathomimetic agents such as ephedrine and pseudoephedrine. Those are big ones that they can't pee after they take them. And you'll see also Benadryl is another one. Urinary retention can lead to nocturia and incontinence from that overflow. Treatment of nocturia depends on the identifying cause. A simple urinalysis you should perform to rule out a UTI, a PSA, blood test, digital rectal exam should be considered to rule out prostate problems. The result of these tests may indicate a need for further diagnostic testing, and specific aspects of the patient education are for this condition should be looked at. Testicular pain is one of the most urgent complaints in your male patients. Testicular pain is an isolated symptom and is typically experienced as a fullness or heaviness of the scrotum, ranging from a dull ache to a stabbing pain, and it can occur in a wide variety of patients with no differentiation based on culture, ethnicity, or socioeconomic status. I provided this chart here so you could kind of see the differences in the various problems and what that anatomy or that pathology may look like on a drawing. You need to be sure and know the definitions and differences between epididymitis, vericocele, and hydrocele. Epididymitis is inflammation of the epididymis. The causes of epididymitis in patients younger than 35 years are usually sexually transmitted diseases such as chlamydia or gonorrhea. There's usually a difference in the type of discharge, as a chlamydia infection produces a serous urethral discharge, whereas gonorrhea produces a purulent discharge. Causes of epididymitis in patients 35 years of age and older include, it's most often E. coli, and sometimes it can be Pseudomonas and Staphylococcus aureus. Epididymitis is often associated with distal urinary tract obstructions in males over 35 years, or those males engaging in insertive anal intercourse. The major complaints of patients with epididymitis is scrotal pain, and it often will radiate along the spermatic cord or to the flank. The pain may appear acutely over several hours, and many patients experience pain at the tip of the penis and complain of urethral discharge and other symptoms of UTI, such as frequency of urination, dysuria, cloudy urine, or hematuria. Elevation of the testes and the epididymis will help to relieve discomfort. And you'll see that patients with sensory neuropathy, because of diabetes, they may not have pain or have minimal pain despite a severe infection or even an abscess. And also older patients may also present without significant pain. Fever and chills with severe infection or abscess formation can happen. On physical examination, you'll find scrotal swelling, and the testes may be indistinguishable from the epididymis. The scrotal wall may be thick and indurated, and a reactive hydrocele may occur. In addition to nodularity of the vas deferens and tenderness of the epididymitis, patients with non-sexually transmitted variety of epididymitis will have pyorrhea. Rectal examination reveals a tender prostate. For diagnostic testing, a UA will show pyorrhea and leukocytosis, and a gram stain of the urethral discharge may stain gram negative, and that's diagnostic for gonorrhea. Culture of the penile discharge may be consistent with chlamydia or gonorrhea infection. So they'll do a gram stain of the discharge, and they'll also do a culture, and that is diagnostic. Chlamydia is the most likely pathogen in non-gonococcal infections. CBC will show WBCs with a shift to the left. Ultrasound of the scrotum can confirm the diagnosis of epididymitis, and vigorous rectal examinations of patients experiencing acute prostatitis should be avoided because this can lead to epididymitis. And remember, we talked about that, prostate massage and sort of the controversy that it may cause other problems. Well, this is one of them. Initial treatment of epididymitis includes bed rest and scrotal elevation with ice packs, along with antibiotic therapy. In patients that are younger than 35 years with sexually transmitted epididymitis, treatment is one-time dose of ceftriaxone in addition to doxycycline. If the patient is allergic to cephalosporins or tetracyclines, a fluoroquinolone such as Levaquin can be used for 10 days. And it's important to treat that sexual partner as well. Patients with non-sexually transmitted forms of epididymitis can be treated with Cipro or Levaquin or Bactrim, and those are for 2 to 3 weeks. A vericocele is an abnormal degree of venous dilation near the spermatic cord above the testes, which usually results in pain and engorgement of the testes. There's no ethnic predisposition or age differentiation among patients with varicoceles. The overall incidence is 8 to 20%. And in males evaluated for infertility, however, the rate of varicocele increases to 30 to 40%. And a weakened vessel wall in the spermatic vein or excessive pressure in these vessels is the leading cause of varicoceles. A varicocele almost always appears on the left testicle or bilaterally. And if you see a right-sided varicocele, it may result from serious pathology that causes increased pressure within the inferior vena cava, such as a tumor or thrombus. So clinical presentation, the patient may present with pain and engorgement of the testes. The recognition of varicocele is usually secondary to a problem with fertility. Patients with a varicocele often describe a sensation of palpating the affected portion of the scrotum, and it feels like a bag of worms. So that's that bag of worms. You'll see that. That's a kind of one of those key words to look for. And this is due to engorgement and tortuous blood vessels. On physical examination with the patient in the upright position, tortuous veins located in the posterior to and above the testes can be assessed. The engorged veins may extend up into the external inguinal ring. Venous dilation can be increased by having the patient perform the Valsalva maneuver while laying down, which reduces blood flow back to the heart. The reverse is also true. In the recumbent position, the venous distension will abate if the patient is not bearing down. In more advanced cases, testicular atrophy with impaired circulation may be present. After varicocele has been diagnosed, referral to a surgeon is indicated. Many urologists also do surgery, although most patients do not require surgery because the majority of varicoceles are minor. And a hydrocele is a collection of peritoneal fluid within the scrotum around the testes. And a hydrocele forms when secretion of the fluid into this space exceeds its reabsorption. So it's just more fluid is flowing in that can be reabsorbed. These collections of fluid may range from only a few milliliters to enormous volumes and measured in liters. And some of you in acute care may have seen this. I've seen it. The incident rate of hydrocele is about 1% in adult males. Most hydroceles occur in males older than 40. And causes of acute hydrocele often are nonspecific, including acute epididymitis, tuberculosis epididymitis, trauma to the testes, tumor of the testes, and as a complication of radiation therapy. And then there's some more complex causes like exstrophy of the bladder, which is protrusion of the bladder through the abdominal wall. And patients with Ehlers-Danlos syndrome may have an increased risk for hydrocele, as do patients with a ventricular peritoneal shunt for dialysis or peritoneal dialysis. Patients with a hydrocele typically present with swelling in the scrotum or inguinal canal. And if the size of the scrotum fluctuates, a communicating hydrocele could exist. So if the fluid fluctuates, there could be a communicating hydrocele. Hydroceles are usually painless, although patients report a sense of heaviness in the scrotum. If there is pain present, it may radiate to the lower back. So transillumination with a pin light and darkened room during a physical examination can help to diagnose this. The trapped fluid appears as light pink or yellow on illumination, and the hydrocele can be illuminated to show the full size and shape, which assists in diagnosis. And the testes themselves do not transilluminate, and hematomas do not either. And you may also see swelling in the groin or the upper scrotum. For adults, no treatment of the hydrocele is required unless complications are present or we suspect a significant underlying cause, such as a testicular tumor. If the hydrocele is painful, large, unsightly, or uncomfortable, several treatments are available, and we should refer to urology for management. Testicular torsion is the twisting or rotation of the testes resulting in acute ischemia, and it's a urological emergency. And this is why it's so important for primary care providers to be able to understand the signs and symptoms and the diagnostic criteria and the physical examination in order to identify it quickly and get these patients out to the emergency room. Testicular torsion is usually an idiopathic and spontaneous occurrence. There's a history of trauma in about 20% of the cases, and a third of people with this problem have had prior testicular pain, kind of episodic. One initiating factor of torsion appears to be contraction of the cremaster muscle, and that can occur during sleep in about 50% of patients. The contraction of the cremaster muscle can also be stimulated by trauma, exercise, and most frequently runners, extreme cold, because it occurs more often in the winter months, and sexual stimulation. Paraplegics are at high risk. One factor contributing to testicular torsion are alterations in testosterone levels and cremasteric contractions during the nocturnal sex response cycle, as well as congenital abnormalities. The most common symptom of testicular torsion is acute onset of pain accompanied by swelling. Excuse me. Torsion of the appendix testes also presents with pain, but it's more gradual in onset. It may have happened over several days before they come in to see you. The most common clinical sign of testicular torsion is the absence of the cremasteric reflex. The testicle may also be high in the scrotum with a transverse rather than longitudinal lie, known as bell clapper deformity. And that's another one of those key words to look for on your boards and other places is that term bell clapper deformity. Elevation of the testes does not relieve testicular pain in testicular torsion. And it does sometimes relieve it in epididymitis, and that's called the Prinz sign. And it's not diagnostic. So if you have a patient with epididymitis and you elevate the testes and they still have the pain, this does not mean that they don't have epididymitis. And the reverse is for testicular pain. Testicular torsion. Occasionally with torsion of the appendix testes, there may be a small lump that's palpable on the superior pole of the testes. And if the skin is pulled tautly over it, the lump may appear blue. And this is called the blue dot sign. This blue dot results from the infarction and necrosis of the appendix testes and is present in about 1/5 of cases. Testicular torsion is diagnosed by history, presenting symptoms, and only a physical examination with initial assessment is required to go ahead and send them to the emergency room. At the emergency room, they'll get some other tests, color Doppler, ultrasound, things like that, but you don't want to delay their care getting diagnostic as an outpatient. And the reason why is compression of the testicular vessels leads to ischemic necrosis of the testes within 6 hours. Failure to recognize the torsion and intervene immediately results in the loss of the testicle 80% of the time, with subsequent atrophy of the testes in 10% of the remaining 20%. Resolution with maintenance of fertility occurs in only 10% of patients. So upon diagnosis, immediate referral of the patient to the emergency department is indicated, as testicular torsion is a urological emergency. Although testicular malignancy comprise only 1 to 2% of all neoplasms in males, and this equates to 1 out of 263 males will develop testicular cancer, psychological and physically debilitating effects of testicular cancer affecting males between 15 to 35 years deserve mention, because testicular cancer is the most common solid malignancy in this age group. Fortunately, it's one of the most curable of all solid cancers. This cancer is less common in African Americans than in the overall population. The peak onset is between 20 and 40 years, with the average age of diagnosis being 33 years. 7% of cases occur in males aged 55 and older. No clear cause and effect relationships have been identified for testicular cancer. We know that prior cryptorchidism is the only undisputed risk factor for this type of cancer. A personal history of previous testicular cancer and a family history of testicular cancer may show greater risk. Higher social status, being unmarried and living in rural areas, also may increase risk. And there have been weak associations demonstrated between hormone imbalances associated with in utero exposure to estrogen that may increase the risk for testicular cancer later in life. As far as screening, we used to tell all our patients to screen themselves once a month by self-examination, sort of like a mammogram, and that has kind of gone by the wayside. It comes back to those, is the benefit greater than the risk? Does it help? So USPSTF has concluded, and also American Association of Family Practice agrees, that teaching young men to self-examine to identify potential tumors and improve outcomes is not supported by evidence. Although currently most testicular cancers are discovered by patients themselves or their partners, either unintentionally or by self-examination. There's no evidence that teaching young men how to examine themselves for testicular cancer would improve health outcomes, even among men at high risk. The American Cancer Society suggests that self-exam may be completed monthly after puberty, and also the Testicular Cancer Awareness Foundation recommends monthly checks, and they have this shower card hanger that you see on the slide to teach men, to remind men to examine themselves monthly. Typically, the patient with testicular cancer presents with a hard lump or nodule in the testicle that is felt by performing a testicular self-examination. Generally, testicular cancer presents as a painless enlargement of the testes. The patient may also note scrotal swelling, heaviness in the scrotum that can be interpreted as pain, a sensation of fullness, or a previously small testes that has enlarged. So changes in the testicle size. During routine examinations, like a sports physical, a scrotal nodule or swelling is most commonly detected. A firm, non-tender mass is palpated. Acute or chronic epididymitis may result in a delay in the diagnosis of testicular cancer in about 10% of the cases. So you want to keep this on your radar when you're looking at a patient with epididymitis. Gynecomastia may be present in 5% of patients with testicular malignancies. Hydrocele may develop secondary to testicular cancer and are seen in 5 to 10% of the patients. So when you're seeing patients for testicle complaints and testicle problems, always keep testicular cancer on your radar. As many as 10% of patients with testicular cancer will be asymptomatic, and another 10% will present with manifestations of metastases, respiratory symptoms, low back pain, nerve root pain, all the things that go along with systemic cancer. There may be several lab tests that can be ordered, biochemical markers can aid in the diagnosis. But mainly they're used for disease progression or to know how the treatment is working once they've been diagnosed with cancer. Scrotal ultrasound is also a useful diagnostic tool for testicular cancer because the mass can usually be clearly seen originating within the testes. Ultrasound will show the mass distinct from the surrounding normal testicular tissue. And you can see that on this picture of a sonogram of a testicle with a mass on it. And I had a patient that had a suspected cancer, and I sent him for an ultrasound, and the ultrasound did not show cancer. And that was good, but it was really kind of inconclusive the way that it was worded, and I didn't really understand it. So again, here, the radiologist is your friend. Don't hesitate to call them and ask them about their impression and if they recommend additional imaging if it's not on there before you talk to the patient. Erectile dysfunction, or AD, is the inability to achieve or maintain an erection that is sufficient for satisfactory sexual performance. That's from your textbook. ED can also manifest as a lack of sexual desire or an inability to ejaculate. ED can result from many causes, including physiological, psychological, endocrine disorders, vascular, and neurological etiologies. So most cases of ED are in males older than 40 years. And it's vastly underreported, and it's estimated that more than 600,000 new cases are diagnosed in the US annually. ED is classified as mild if the patient fails to achieve a satisfactory erection in 2 out of 10 attempts. And if all attempts at satisfactory erection fail, ED is classified as severe, and moderate if ED falls within the middle ground. There is a sexual history inventory for men, or SHIM, which is a 5-question screening tool for ED. So it's difficult to estimate the number of males with ED because the definition's broad and because people may be reluctant to seek medical attention for the problem. Transient limited episodes of impotence may occur in about 1/2 of all adult males at some point in their life, and those are not pathological. Aging affects sexual functioning, and more than 33% of males by age 55 years of age have ED. Most cases of ED have an identifiable physical as opposed to psychogenic cause. In fact, the rate of ED increases as the rate of cardiovascular disease increases. This slide shows the multiple causes for erectile dysfunction, and you can find this table in your textbook. I took this right out of your textbook. It's critical for you as primary care providers to assess both the physical and the psychological aspects in a patient with ED complaints and make appropriate specialist referrals if needed. Because in some cases, ED may result from a combination of both physical, psychological, and emotional causes. A key question to ask is whether the patient with ED still experiences sexual arousal despite the inability to achieve or maintain an erection. A failure to generate the nerve impulse required to initiate an erection may be caused by a number of endocrine problems and neuro problems, or it can be psychogenic in origin. ED can also be the result of failure to adequately fill the penile blood vessels due to cardiovascular issues. A loss of libido may indicate androgen deficiency arising from either a pituitary or testicular disease, resulting in a failure to initiate the nerve impulses needed for an erection. Medications are a common cause of ED, either directly or through adverse effects. Loss of erection can be caused by central sympathomimetic medications such as methodopa, clonidine, reserpine, whereas alpha blockers cause a few problems with erection, the ones that are used for BPH. However, beta-adrenergic blocking agents such as metoprolol, labetalol, and also spironolactone can contribute to the physical impairments in achieving erection and can cause a loss of libido. And this can be a reason for people to be non-compliant with their hypertension medications. Other medications such as calcium channel blockers can increase prolactin secretion and thereby cause ED. Selective serotonin reuptake inhibitors, SSRIs, are known to cause ED. And some drugs of addiction can decrease testosterone levels and lead to ED. In addition, zinc deficiency seen in malabsorption or malnutrition symptoms can also be a problem. For diagnostics, initially laboratory tests that rule out various causes of ED should be done. These tests include fasting blood sugar to rule out diabetes, a lipid profile to rule out dyslipidemia, thyroid stimulating hormone, and a testosterone level. If the testosterone level is below 300, a serum prolactin level is warranted. Laboratory tests for patients with ED should include a complete blood count, a blood chemistry, a TSH level, and a PSA in males as young as 40 years of age if they have a family history of prostate cancer. Most males older than 55 years will have some abnormal laboratory findings or risk factors, but these may not necessarily be the cause of ED. Several specialized tests can be done, but only if the cause of ED is not apparent after the standard testing regimen. Hormonal therapy should be managed by a clinician experienced in the evaluation and monitoring of patients on hormonal therapy. Testosterone is a Schedule III controlled substance, and sildenafil Viagra has become one of the most commonly prescribed and used pharmaceuticals available today. And one study, a cross-sectional survey conducted in undergraduate institutions within the United States, revealed that participants had recreationally used erectile dysfunction medications, specifically Viagra, at least once in their lives, 4%, and some with current use, 2%. The majority of recreational EDM users reported mixing erectile dysfunction medications with illicit drugs, and particularly during risky sexual behaviors. Because of the potential for recreational use of ED medications, referral to urology for evaluation and management once you've done your screening and have diagnosed erectile dysfunction, this referring to urology can add a level of safety for your patients. Another reason is that patients on testosterone therapy should undergo monitoring prostate examinations and PSA screening tests, even the theoretical risks of BP, even given the theoretically risks of BPH and prostate cancer associated with testosterone exposure is enough to warrant these screenings. Blood levels of testosterone and other regulatory hormones should be followed to prevent the sequelae of medication overexposure. Interpretation of these hormone levels requires expert knowledge. If a psychogenic cause is involved in ED, such as performance anxiety and relationship problems, referrals to sex therapy and couples counseling may be helpful. Therapy can be used in combination with other therapies. In addition, all of the invasive surgical interventions described in your textbook require appropriate referrals to a qualified urologist or pelvic surgeon. Testosterone levels peak during adolescence and early childhood and then gradually decline about 1% a year after 30 years of age. As males age, there's a rise in the level of follicle-stimulating hormone, which controls sperm production, as well as luteinizing hormone, which controls testosterone production. Simultaneous to this is a decline in testosterone levels. Testosterone may decline as a function of normal aging or may be due to hypogonadism. Other factors that may suppress testosterone levels include stress, obesity, tobacco, alcohol use, obstructive sleep apnea, type 2 diabetes, and illness. Medications such as Germanin, ketoconazole, glucocorticoids, ankylate agents, and opiates may cause a decrease in testosterone if used chronically. Low testosterone or low T affects multiple body systems. Cardiovascular effects include dyslipidemia and hypertension. Metabolic syndrome consists of these disorders in addition to obesity and glucose intolerance, which collectively increase the risk of cardiovascular disease. Low T is associated with diabetes type 2, and patients with the lowest levels of free testosterone are 4 times more likely to have diabetes. Osteopenia, osteoporosis, and fracture prevalent rates are greater in hypogonadal patients, with 30% of fractures occurring in those with low T. Of course, erectile dysfunction and decreased libido correspond with a decline in testosterone, which regulates the nerve structure and function in these areas of the spinal cord that are involved in erections. In addition, a decline in mental functioning has also been associated with low T. Diagnosis of testosterone deficiency is completed on lab tests and physical exam and history. And the treatment is hormone therapy, and this should be managed by an experienced clinician. There's an increased risk for BPH, so prostate exams and PSAs should be routinely done or recommended. Hormone levels should be rechecked periodically, and those should be interpreted by an experienced clinician. Remember that testosterone is a controlled substance, and that for nurse practitioners, that brings in another level of management. Thank you for listening to this video, and I hope that it helps you prepare for your exam. Some other study tips I could advise is to seek out audio video resources aimed at family practice board exam prep. This can be either medical or nurse practitioner. I find it helpful when searching for free videos on YouTube to type in medical family practice board reviews. And then it'll pop up some of these professional organizations that do board reviews. There's also nurse practitioner board review professional reviewers who sell their whole board review in audio and video format that are available online. And that if you're getting ready for your boards, it might not be a bad time to go ahead and start doing that, because viewing those types of resources will also help you prepare for course exam, program exams, and also it'll help you in clinical. Complete the study guide table. And strangely enough, studies have shown that learning occurs during the process of writing by hand. And I know this has kind of gone out by the wayside. People like to copy and paste and then read it. And that's fine too if that's the way you learn. But studies have shown that kinetic movements along with tactile stimulation of the act of writing has been shown to help information register in the brain. So consider handwriting the table. And of course, read your textbook chapters. Everything that you need to pass this course is within your chapters and other resources that are provided within the course and Fitzgerald. So be sure, and reading is probably the best way. And also look for additional resources from audio, video, write, those type of things, help you to retain information and for it to make sense. And another tip is to don't cram. Always allow yourself to sleep before you take a test, because you can put all this information in your brain, and while you're sleeping, it will reorganize and it'll make more sense the next day. I know that the old saying, let's sleep on it, there's a reason why that came up. So don't hesitate to reach out for questions or concerns, and I'm here to help. Thank you. Bye.